Please welcome Michael Murphy, founder and executive director, Mass Design.
I'll just start with the idea that when we go to a hospital, we presume we're going there to get better. But as many of you know, that's not always the case. In this medical facility in Tugela Ferry, South Africa, patients who walked in sat in this unventilated hallway and walked out with a multi-drug resistant strand of tuberculosis. All of them that contracted it died. And simple designs for infection control could have mitigated this, as so the director of the hospital explained later on. If hospitals are making people sicker, let's say buildings are making people sicker, how can we design medical facilities that can actually make us healthier? Not make us less sick, but actually make us healthier. This principle about using architecture as a productive engine for, let's say, social change and also health emerged in this opportunity I had to work in northern Rwanda with the organization Partners in Health and build a new national hospital in 2008. The Butaro Hospital opened in 2011 based on this principle that we could potentially use this building to heal, to mitigate disease, and fundamentally change the way we understand the building as something that activates change instead of just is a place where things happen. But the question of can a building heal is, of course, a challenging one. Is it provable? Is it measurable? Simple things we can do that can address this. For example, designing the building in such a way to reduce infections through natural ventilation. In this design of the clinic, we thought about a couple simple human-centered strategies to think about disease transfer as well as the behavior of patients and of nurses. If hallways are making people sicker, for example, why not turn the hospital inside out and put hallways on the exterior where air mixing is most beneficial? If mechanical systems rarely work, why not design a hospital that uses natural ventilation and meanwhile reduces its environmental footprint? And what about the patient's experience? Typical hospitals that we saw in our research, like this, were quite troubling. But evidence had shown that a simple view of a window could radically improve health outcomes, reducing pain medication and getting patients out of the hospital quicker. So why couldn't we design a medical facility that gave every patient a window with a view? Simple designs, strategies like this could radically improve health outcomes, or so we hypothesized. But then could we prove them? Turns out we did have great results at the outset of this, and measurable studies have been going on since the introduction of patients here in 2011. We've had the largest drop in infant and maternal mortality ever recorded in the last 100 years on this site in Rwanda. An incredible testament to the fact that the healthcare intervention, at least at the system scale, is having significant impacts. Of course, our question is, what was the role of the building in having, or at least participating in some small way or in a large way, these kinds of great medical outcomes? This question is one we have to really ask ourselves. It's not so much does it or does it not, but in which way. And that opportunity, I think, is why we need to be thinking about how we measure design so significantly. So we as an organization began with that challenge, can a building heal, and see real results. We're convinced that a building can affect health. But how it affects health is something that is challenging in architecture, and we have to, I felt, divide up the impacts of buildings so that we're all speaking the same language. So we begin with this fundamental core question. What is the mission of a building? We believe every building does have a mission. And the mission is related to the direct impact that we seek to measure, in this case, health outcomes. And as we worked over the last 8 years in many different projects, the first work that we do with our organizations is to isolate what is their fundamental mission. Heather mentioned sometimes getting a design brief where that mission or potentially that problem is already articulated. Our fundamental first exercise is to figure out if they've articulated the right problem and if a building is even necessary. These are conditions where we did see that the building could radically improve the say, performance and outcomes of the organization's fundamental mission. In this case, in Haiti, they're fundamentally addressing the issues of an epidemic of cholera. So this center is built around, and its form is based around strategies to mitigate and reduce the infection from cholera. Here, in fact, we've seen the reduction, also in Haiti, a tuberculosis clinic, the reduction in suicide by putting patients from tents into this, a radical proven outcome from just moving them across the yard. We've seen or tested the idea that a new building could help cancer patients maybe improve their take of medication, or even the idea that better housing can improve doctors' performance, or even the idea that architectural teams of medical professionals can be improved in their performance through better living conditions. Or we might ask whether a school can improve educational outcomes or reduce dropout rates. All of these mission-oriented questions are the ones that must drive, right, the design of the building. And we know that architecture clearly has impact, but it's hard to measure these things. And sometimes the measure might be incorrect. And so when we scan, let's say, the field of design of architecture, like the built environment, we see a range of different efforts to measure, but they're not always speaking the same language. And we knew that it's not just about, let's say, health outcomes that makes architecture fundamentally impactful. It's also the process of building that makes it impactful. In Rwanda, in the Butaro Hospital, we were deeply engaged in this community, hiring over 4,000 people to build the hospital, working closely with artisans to make this stone wall and compressed stabilized earth block to reduce environmental impacts and make a kind of radical carbon neutral building. We also invested heavily in training folks in the building process. And in fact, these other effects of architecture have impact. We call them the 4 E's: the environmental impacts, the economic impacts of good built infrastructure, the opportunities for training, and then we might say the emotional impact. Right? Great architecture can produce dignity. And this idea, this unmeasurable, is also incredibly important for us not to forget. And so we've developed a kind of framework to try to understand what impacts we're having, but also so that we're speaking the same language. We might call this the direct and the indirect. And the 4 E's are a helpful reminder that we are measuring many of these things in the built environment, but it is not enough if we only measure one of them. Of course, environmental impact is being measured through policy, and many architects speak about the environmental impact of building through certifications like LEED or BREEAM and others. Incredibly important that we're speaking the language of the impact of our buildings on our environment. But if we understand a bigger picture, we also recognize that there is a deficiency in measurement in these other categories. And so we went through we're going through a 3-year research analysis of the field itself. And our hypothesis was, in fact, supported or substantiated. Looking at all the different measurement systems of the built environment, we see incredible work going into, especially the environmental impact, as you can see in the middle, but almost no measurement around what we might call the mission of the building itself. And later, and Cheryl mentioned this, the systemic impacts of buildings on, let's say, the larger economic development or even the policy of those countries. We saw that happen in Rwanda. The government adopted our standard plan as national policy. So how are we measuring the impact of buildings on systemic change? These things are not happening. There's a huge void in the system, and we have to address that. We have to understand the field itself and find ways to support that. So let me walk you through a project which had a challenging mission and a strange outcome. This was a school in one of the most remote places in the world, in rural Ilima, Congo, Democratic Republic of Congo. And the organization, the African Wildlife Foundation, was building this first pieces of crucial infrastructure with the mission to protect endangered wildlife, to reduce bushmeat, killing of bushmeat, as well as to help the local residents think about conservation as something that's productive, as an asset instead of a liability. So in this condition, we moved a team to this area for 2 years. And this is a kind of extreme example of what we might do with social, some might call social architecture, we call architecture, an architecture that's deeply immersed in the community. The first, of course, is environmental. We could bring no materials into this place. It was 3 flights and a 6-hour motorcycle ride. So even the idea of importing materials was impossible. But this kind of radical local architecture enticed us, and we wanted to see if we could accomplish that. So of course the environmental impact was incredibly let's say, astronomical in terms of comparisons. We source 99% of the materials within 10 kilometers of the site itself, within a very, very small radius. Every single material here was made from this community, from this area, and we had to think about those materials like an architect used to think about them, right? Building from what we have locally. When we started to measure this in, let's say, and compare it to other buildings, and we've done this recently, there isn't even a measurement for building with local mud construction and felled trees. There isn't even a measure. We have to create the measurement to even plug it into these models. But as you can see, the construction of Alima emitted 28 times less carbon than the global average for educational construction projects. And you can see the Beijing Olympic Bird's Nest Stadium and the vast amount of embodied carbon in that project. So here we have a kind of radical embodied carbon strategy of our architecture, incredibly sustainable, if you want to use that word, but I would even go further to say environmentally just. The opportunity to think about local sourcing is not just about material, but also about labor. And the investment of those dollars, every dollar invested in a place is an opportunity potentially to think about how we're engaging the community in which we're working. 74% of that money was spent locally, and I mean locally within 100 kilometers, right? The rest of it was spent within 800 kilometers, right? The kind of countrywide. We created an enormous amount of jobs on this project. Most of that money goes directly to labor. 748 equivalent full-time year-long jobs created just by doing this project itself. So the economic impact is substantial, right? So we can track these things, and we need to track these things. As you can see, we did enormous amount of skills training also with this project. For us, this school is an innovation. Zico Lakuli said, we didn't know that this earth mixed with this clay from that hill could be used to build something like this. We were working on innovating strategies with local construction and improving the overall quality of that design, in this case, the construction of mud block, in order to improve the overall quality of the construction of buildings in the entire region. And one of the things we will measure is if these methods are replicated, right, further into that community. And then, of course, there is what we might call the emotion, like, is this actually changing the way people think about conservation, about endangered species, about education, about opportunities, about dignity? Now, that, of course, is a good example of measuring the 4 E's, but can we measure the reduction in poaching of endangered species? And that is something the African Wildlife Foundation is doing, and can we tie directly to our school is a challenging thing. So I wanted to show a couple of examples, 2 examples of where we're looking at directly measuring the project's mission. It's not just that it's difficult to fund it, right? It's difficult to get someone to buy in to support the long-term investment in measurement of the core direct impact we're seeking to achieve. This we've found incredibly challenging. We've built an entire research team. We've applied for grants. We have some support. But these are multi-year studies to prove direct impact, and they need to be supported. Here in Malawi, we built a maternity waiting home. And the government's strategy was to build 100 of these all over the country. They had, and very, very kind of low cost. But the idea was to bring women to the hospital early and reduce maternal mortality. We had the same strategy of the 4 E's, but in this one we had a measurable outcome that we could see, and we had a baseline. They had already built maternity waiting homes that were doing poorly. Women did not want to go to them. And so they weren't actually seeing reduction numbers. So this new design, which we finished last year, we're having a huge amount of increase in people coming to this particular hospital. And we see this as a prototype which to be replicated. Again, earth blocks, radical carbon, embodied carbon strategy, a place that can accommodate both what it was designed for, what it wasn't designed for. They only could pay for 36 beds, but they had 300 women, right? So the brief was completely wrong, but we still had to accommodate that. So a lot of outdoor space, a lot of environmental strategies in the way it was designed. And we could not get, we've applied for many, many grants to fund this, even with a baseline. We've had a very difficult time getting the funding to this, so we funded it ourselves. And now we're doing a kind of series of surveys, a series of a long-term, year-and-a-half-long study to show that this project itself is having significant impact on the reduction in maternal and infant mortality itself. one of the key things we can measure is, do women prefer to go to this than the other one, this facility than others? Did they go back to their villages and say it was an amazing experience and you should do it as well? Is this bringing more people to the facility? Design might have a direct relationship to that. The architecture itself might have a direct relationship to the desire to participate in this program. Another really exciting project that we have gotten funding for is working through the Robert Wood Johnson Foundation, working with the Ariadne Labs at the Harvard Public Health School, Atul Gawande's group. And I gave a lecture there, and a young doctor came up to me and said, you know, I have this hypothesis that there is a radical difference in cesarean section rates in hospitals across the US, and I think one of the reasons is spatial. The rates of cesarean sections vary widely, right, from 70% to 7% in different hospitals around the US. And these are, of course, the healthiest patients. And of course, it's about behavior of doctors, it's about the load of patients, but one key thing is it is potentially spatial, right? And so we've gone into this project for the last year and a half, and we're going into the second phase, where we have this unique and targeted strategy to look at the implications of the design of the space on the health outcomes of these mothers. So first we convened a great group of experts to identify and validate a set of design elements that may impact the care and cesarean delivery rates. Then we created a scalable methodology for collecting and quantifying qualitative design data. So these kinds of worksheets we've been sending out and encouraging medical facilities to come to us and to participate. And then third, we measured the plans of these L&D floors of various different types of medical facilities across the US and brought people together to talk about whether these outcomes, and they vary, of course, are related to or not related to the design of the space itself. And if we could have incremental adjustments, could that address and reduce the rates of cesarean sections that we're seeing throughout the L&D floor? So to me, these are examples of us finally getting to a place where we're getting some financial support and grant funding and partnerships that are looking at direct outcomes, right? Looking at design and the mission of the project and its direct outcomes. And it helps to push me to think about architecture itself as moving on this continuum between, let's say, art into behavioral science. And why I put this up there is because many architects reject the idea that architecture can shape behavior, right? In fact, it's debated within the academy. And this has led to a sort of dearth of research. It's led to a lack of a disciplinary commitment to measure what can be done, what behavior can be shaped, and what behavior cannot be shaped. And this, I think, is a real problem. It's why I think we're in kind of year zero of measuring the direct impact of architecture, because there's still a debate. In my mind, there's not a debate, right? It is clear that architecture shapes behavior. It's just what behavior it shapes and how do we measure it. And so what we're engaging in is trying to develop not only a disciplinary agenda, but also in our own practice to prove what we can prove, to reject what we can't, to measure those that we know we can measure, and then to also build a field, right? To say that in 20 years, we're going to have real data that shows the effects of architecture on our health, on our lives, and our communities. Thank you.